I'll let Dr. Demars and Dr. Ray introduce themselves and get rolling.
Great. Hi, everybody. I'm Dr. Demars. I am a hospitalist at the VA, and I'll be taking you through some MKSAP questions today with our GI expert, Dr. Ray.
Hi, I'm Dr. Ray. I'm mainly over at Heart Review, so come say hi. And I will be with you guys today. I specialize in motility.
Excellent.
Which we have some good motility questions today. So
great. All right. With that, we'll just jump in, and I apologize. I don't have polling for all of you, so feel free, if you're not shy, to put things in the chat if you want, just to kind of get out there what people are thinking the answers are before we move on to the answers.
Sandra, just so you know, we can throw up a generic poll for each of the questions, which may
good.
help. Yeah.
I didn't know if we got that working. Excellent. Yeah, let's do that. Let's see kind of where people are thinking about questions.
Sounds good. I can do that. I can run the poll.
Perfect. Thank you. All right. Question 1. A 75-year-old man is evaluated. Oh, I can't even see the top. Oh, well, progressive dysphagia. I don't remember what it was, of 3 months, maybe, or 6 months duration.
8
of
months.
both solid food and water. 8 months. Okay. Like, I can't see that first line. And the necessity to induce vomiting several times each month to relieve his symptoms. He also has experienced chest pain and heartburn symptoms. He has lost approximately 6 kilograms or 13 pounds of weight over the preceding 3 months, and a total of 9 kilograms or 20 pounds since his symptoms began. He has a long history of cigarette and alcohol use. His medical history and review of systems is otherwise negative. He has no travel outside the northeastern United States. He takes no medications. On physical exam, his vital signs are normal. BMI is 23. He appears thin and tired. The remainder of the physical exam is unremarkable. Upper endoscopic findings reveal retained saliva, food, liquid, and food in the esophagus without mechanical obstruction. Manometry demonstrates incomplete lower esophageal relaxation and aperistalsis. So which of the following is the most likely diagnosis? A, achalasia, B, Chagas disease, C, eosinophilic esophagitis, or D, pseudoachalasia?
All right, I've gone ahead and launched the poll. Folks are responding. Give a couple more seconds here. All right, I'm gonna go ahead and end the poll here. Should be able to see there's
a lot of people for A. Yeah, can everybody see that? Yeah, lots of A, some D's, and a couple E's. Oh, there's no E. Maybe either way. No one for maybe B or C. All right, so we will move on to the next slide. And the answer is actually D, pseudoachalasia. So just a little bit about that. It's also called secondary achalasia. It's an esophageal motor abnormality caused by functional loss of the mesenteric plexus ganglion cells of the lower esophagus and the GE junction. Most commonly, it's caused by infiltration of the plexus by tumor. Those are the cancers most commonly associated. People typically present later in life, 6th decade of life or older, have a short duration of symptoms and experience sudden and profound weight loss. An EGD or an ultrascopic ultrasound should be used to diagnose a possible tumor that can't necessarily be seen otherwise. Other benign causes are amyloid, sarcoid, or post-surgical. And the symptoms, the barium imaging, manometric findings, and endoscopic appearance can be similar to achalasia. So just to touch a little bit on the other options. So achalasia, oppositionally, affects men and women equally. 1 in 100,000, occurs a little bit younger, between the ages of 30 and 60. It has more of an insidious onset and a longer duration of symptoms before patients seek medical attention. Just like pseudoachalasia, they have dysphagia to solids and liquids. They often have regurgitation of undigested food and saliva as well. So it can be similar in presentation to pseudoachalasia and Chagas disease, and they can have similar imaging findings as well. So in this case, the patient's age, the short duration of symptoms, and the rapid weight loss make achalasia less likely. Chagas disease is caused by a parasite, so typically involves people that travel to Latin America. The parasite goes in and directly destroys the mesenteric plexus. It can also affect multiple other organs. And so for this patient, lack of other symptoms and lack of travel make it less likely. And eosinophilic esophagitis is typically in younger patients, and they typically present with a food bolus obstruction. And you can see changes on endoscopy, such as rings and furrows. And so this is not consistent with the patient's history and endoscopy findings. Dr. Ray?
Yeah, this was tricky because when you first glance at it, it really does sound like slam dunk achalasia, which typically can present earlier in life for patients more like middle age. Typically, the clinical presentation is dysphagia to solids first, then liquids as the lower esophageal sphincter continues to get tight. The wording of the manometry findings is a little weird too. It's aperistalsis, and it should be, complete lack of lower esophageal sphincter relaxation. The incomplete is kind of weird also. Going off the question stem with his smoking and alcohol history, they're kind of asking you to think that he has cancer also. So that would lead you more towards like a pseudoachalasia diagnosis, but I will admit this question is tricky for sure.
Anyone have any questions about this question before we move on to another one? Feel free to speak up or type in the chat. Okay. I'll move on. I can't really see the chat, so someone else speak up if there's something I'm missing. Okay, question 2. A 52-year-old male is evaluated for dysphagia of 3 months duration. He reports regurgitating undigested food soon after eating solid food, occasional coughing and choking after swallowing, and chronic halitosis. He reports no weight loss or chest pain. He drinks 2 beers weekly and does not smoke. On physical exam, vital signs are normal. BMI is 25. The remainder of the exam, including the abdominal exam, is unremarkable. So which of the following is the most important diagnostic test to perform next? Is it A, a barium esophagram, B, esophageal manometry, C, 24-hour esophageal pH monitoring, or D, an EGD?
Okay, I've gone ahead and relaunched the poll, so folks are responding. Give a few more seconds here. People to get their final thoughts in. All right, I'm gonna go ahead and end the poll.
Okay, we've got a lot for A, some D's, and then a couple E. All right, so most people got this correct. The answer is A, a barium esophagram. So what does that mean the diagnosis is? Does anyone want to speak up or type, explain why they thought that was the best test? Oh, there's some chats.
Yeah, I see a few people in the chat. There's a lot for Zinkers. I think five in a row. Saying Zinkers.
Excellent.
Zinkers.
Strong work, people. Good. All right. Diverticulum, so dysphagia with regurgitation of undigested food. Other common symptoms are halitosis and gurgling in the chest. Diverticulum is located in the cervix. I think this is the wrong PowerPoint. Hold on, I might need to launch the next one because I think, yeah. Okay. Maybe not. Here, we'll keep going. Sorry. So the diverticulum is located in the cervical esophagus. Complications include aspiration and pneumonia. The best initial test is the barium esophagram, and treatment is reserved for symptomatic patients. In places where there's expertise, an endoscopic diverticulectomy is performed. In places where they don't have those specialists, then there's surgery by external neck excision. So just to touch on the other options for the testing. So the manometry is used when there is concern for a motility disorder. This patient, however, only reported dysphagia to solids. With motility, just typically have dysphagia to both solids and liquids. 24-hour esophageal pH monitoring is for ambulatory pH testing that can identify acid exposure. These tests are often used to evaluate patients with symptoms of GERD who've not responded to medical therapy. So a peptic stricture could be causing solid food dysphagia that results from untreated reflux, but this patient's symptoms of regurgitation of undigested food is more consistent with Zenker's. And then endoscopy, as you all know, is used to inspect the mucosal surfaces. And although endoscopy could see a diverticulum, there's a risk of perforation if the endoscope enters the diverticulum. And so that's why the first choice is for the barium esophagram.
Yes, this clinical presentation is pretty classic. I had a patient like this who also had some reported nasal regurgitation of food, which led me to think she had a Zenker's. I found it during an endoscopy, so the referring provider asked for a scope. It's a wee tricky, but it's pretty easy to determine esophageal lumen versus the diverticulum when you're first entering through the upper esophageal sphincter space, unless that is a pretty huge diverticulum. So is it wrong to ask for an endoscopy? No, but the clinical presentation makes Zenker's a little more likely. I would say if your barium esophagram is non-diagnostic, then I would do an upper scope, just rule out any other obstructive causes and take a good look at the esophagus. Also, but your initial test should be the barium esophagram.
Excellent.
And there's a sort of related question in the chat from Jordan. How often would you expect to incidentally catch a diverticulum on endoscopy? For example, like if endoscopy doesn't show a diverticulum, can you rule it out?
Yeah, so we have to be very careful when we're doing these tests. It's really important to get a good clinical history for that patient. I suspected it, so as I was withdrawing out of the esophagus, I made sure to take a very good look because it tends to be proximal in the esophagus, so it's very easy to miss it. If you just fly your scope back when you're done with the test, and you'll definitely miss it. So if I expect to find it during the scope and I don't, then my next step would be the barium esophagram if that hasn't been done yet.
Excellent, thank you. I'll go on to the next question if there's no other questions on this. Okay, 65-year-old female is evaluated for watery, again, I can't see the top, but I know it's non-bloody diarrhea. I don't remember how long.
8 months.
8 months, perfect. She reports up to 6 bowel movements per day with nocturnal awakenings, but no abdominal pain, bloating, flatulence, or weight loss. Her last screening colon at age 60 was normal. She has no personal or family history of colon cancer or polyps. She also has osteoarthritis, and her only medication is ibuprofen approximately 3 times weekly. The patient is not exposed to children and has no recent travel history or engagement in outdoor recreational activities. On physical exam, vital signs are normal. The remainder of the physical exam, including the abdominal exam, is normal. Laboratory studies show hemoglobin, serum albumin, total IgA, and tissue transglutamase IgA levels to be within normal limits. Which of the following is the most likely diagnosis? Giardia, microscopic colitis, small intestinal bacterial overgrowth, or ulcerative colitis?
All right, should be seeing the poll now. See some answers coming in. We have about 10 more seconds here. All right, I am going to go ahead and end the poll here.
You guys are too good. Number B, letter B, 87% of you chose B, microscopic colitis. And that is indeed the answer. So a little bit about microscopic colitis. In about 10 to 15% of patients that have chronic watery diarrhea, the underlying cause is microscopic colitis. It's more common in older persons. It does not cause endoscopically visible inflammation, so you don't see it on a colonoscopy. Symptoms are similar to other chronic causes of non-bloody diarrhea, such as IBS or celiac disease. Colonic mucosal biopsies are required because you can't see it on colonoscopy. The disease can be patchy, so random biopsies from multiple colonic segments are necessary. Lymphocytic and collagenous colitis are the two subtypes of microscopic colitis, and they're only distinguishable histologically. In some patients, medications like NSAIDs or PPIs have been implicated as causative agents. It is associated with other autoimmune diseases such as diabetes or psoriasis. And so because of that, in patients with celiac disease or microscopic colitis, if they're not responding to treatment, you should consider the other one because they can look the same. And I think, let me see if I have something on, oh yeah, okay. So Giardia, infectious cause of persistent diarrhea in immunocompetent hosts in developed countries. So we certainly see it here, should be considered in patients with exposure to young children or possibly contaminated water, lakes or streams. This patient did not have any of those risk factors. Small intestinal bacterial overgrowth causes diarrhea, but often patients also have bloating, flatulence, and weight loss. Conditions that affect the stomach acid or the intestinal transit or disrupt the normal antibacterial defense mechanisms can predispose patients to small intestinal bacterial overgrowth. So gastric bypass is an increasingly common cause of it. This patient didn't have any malabsorption symptoms or weight loss, making this diagnosis unlikely. And then ulcerative colitis typically presents with bloody diarrhea. Patients also have abdominal discomfort, the severity of which is related to the severity of inflammation. It also typically involves the rectum. And so patients have tenesmus, urgency, rectal pain, fecal incontinence. Some patients can present with constipation due to rectal spasms and stasis of the stool. Patients with severe disease can have fever and weight loss. So again, these patient symptoms are not typical for ulcerative colitis. Dr. Ray?
Yes, this patient has a pretty classic presentation for microscopic colitis. She's in the right age group, and you see that, that keyword of NSAIDs, you should be thinking about microscopic colitis. SSRIs can do it also, so keep that in the back of your pocket too, as well as NSAIDs and PPIs. So again, we do see often a normal colonoscopy, and it's important to take tissue samples from the right and left colon to look for this disease. Treatment is first line treatment, because someone asked about that, is stop the offending agent. A lot of times if these people are still taking these medications, they'll still be, giving themselves microscopic colitis. So it's important to stop the treatment. And second line therapy, if you've ruled out medication causes for microscopic colitis, is steroids, particularly budesonide, because it has a better side effect profile than prednisone. Typical treatment is between like 6 to 9 weeks, depending on how much you want to do. Is a repeat colonoscopy necessary to make this diagnosis? Do you mean after treatment for microscopic colitis? I don't necessarily do that unless a patient is still having disease or symptoms of diarrhea, after treatment. With budesonide, I would consider doing a repeat scope with biopsies to see if there's other secondary causes that are versus kind of persistent. Oh, no, you should get tissue to get a diagnosis. Thanks for clarifying that question.
Excellent. Great. Any other questions? All right. Oh,
no,
there's something.
Is the answer to
Okay.
that.
Thanks.
Yeah.
So folks
All right.
who may not have been able to see the chat, is there a risk of progression to malignancy? The answer is no. Yeah.
Excellent. All righty. Next one. 25-year-old. Oh, I can't see the top. Can someone read that first line?
Sure. 1 month history of intermittent loose bloody bowel movements.
Thank you. Associated with pain in the left lower quadrant before defecation. The bleeding occurs with and without bowel movements. She reports no fevers, chills, night sweats, arthralgia, eye pain, or rash. The patient works in a daycare center, has not traveled or used antibiotics recently, and doesn't take any medications. Physical exam is pretty unremarkable. Vital signs are normal. She has a soft scaphoid abdomen with some suprapubic tenderness. Stool testing for bacterial pathogens, including C. diff, is negative. Colonoscopy shows pachyarthema and ulceration in the cecum, ascending colon, descending colon, and sigmoid colon, with no involvement of the transverse colon or the rectum. Mucosal biopsies of the involved mucosa reveal distorted and branching colonic crypts with lymphocytic and neutrophilic infiltration. Ileal examination is normal. Which of the following is the most likely diagnosis? A, Crohn's disease, B, Giardia, C, microscopic colitis, or D, ulcerative colitis.
I'll go ahead and relaunch the poll here. There you go. Folks should be seeing the poll now. I think some people are thinking hard about this one. Give a couple more seconds.
Well, they can't know all of them. Otherwise, this is fruitless.
All right, I think most folks have answered, so I'm going to go ahead and end the poll here.
All right, we've got a mixture, 64% for A for Crohn's and 36% for ulcerative colitis. So that's helpful. So our answer is Crohn's disease. So, you know, similar to ulcerative colitis, symptoms are abdominal pain and diarrhea and weight loss. The overt GI bleeding is less common in Crohn's, but can occur. We do typically, you know, think of it more with ulcerative colitis, but they can have varied presentations, which can make the diagnosis difficult. So the diagnosis really depends on the pattern of inflammation, these so-called skip areas, so affected colon and then unaffected colon. And these histologic features of distorted and branching colonic crypts can help identify it from some other inflammatory conditions, but really it's the skip areas. So Giardia doesn't cause inflammation, no bloody diarrhea. Remember, that was just watery. Most patients are asymptomatic, but those that are symptomatic can have some abdominal cramping, and again, this large volume of watery, foul-smelling stools. Microscopic colitis also does not cause bloody diarrhea, only watery. And as we talked about the colonoscopy, like visual inspection will be normal. And it does occur typically later in age 60 to 70, and more so in women. Ulcerative colitis begins at the rectum and progresses up the colon in a continuous pattern, so there's no skip areas. The biopsies will show the distorted and branching colonic crypts as well, but it's, you know, the skip areas that are important here. Dr. Wright?
Yeah, so yeah, that history is pretty classic of almost daily frequent bloody diarrhea. I would suspect inflammatory bowel disease. The others, like Giardia and microscopic colitis, do not present with bloody diarrhea. It's just chronic watery diarrhea. For Crohn's versus ulcerative colitis, as the answer prompt states, the ulcerative colitis will always involve the rectum and extend up. Crohn's will have skip lesions. Remember, your pathology should show architectural distortion is what we look for diagnosis of inflammatory bowel disease. If it's just active colitis, that could suggest a possible infection, like a stool infection.
There's a couple things in the chat. I think Dr. A, one of the things that you put in is just calling back to the micro microscopic colitis. Okay, about patients still having diarrhea despite stopping therapy. And Vanessa and I look for celiac. And then Luke's question. I'm sorry, did you just answer?
No, I didn't.
Okay.
So yeah, if someone has neutropenic cryptitis, so just kind of active colitis, I'm not sure if the pathology mentioned anything about chronic inflammation or crypt distortion. I wouldn't necessarily correlate that with IBD automatically. It depends on what your patient's symptoms are. I would do further investigation. If fecal calprotectin will be elevated, probably because the patient has some evidence of inflammation in the colon. But I would do other things like look at the small bowel with a video capsule versus like quicker would be a CTE or an MRE. Oh, it's a screening colonoscopy and they're asymptomatic, then yeah, I wouldn't call that IBD.
All right. Any other questions? All right, I'll move on. 78-year-old male is evaluated in ED for worsening jaundice of, is that
2 weeks?
2 weeks, thank you. 2 weeks duration, dry mouth, dark urine, and light stools. He's also noticed swelling under his jaw bilaterally. He reports no abdominal pain or weight loss. On physical exam, vital signs are normal. He has swollen submandibular glands bilaterally. Labs are notable for an ALK Phos of 180, ALT 66, AST 55, T-Billy 6.2, direct Billy 4.8. A CT abdomen shows a narrowed pancreatic duct and enlargement of the pancreas parenchyma, described as a sausage-shaped pancreas, as well as findings consistent with retroperitoneal fibrosis. An endoscopic ultrasound guided biopsy of the pancreas shows more than 10 IgG4 positive cells per high-powered field and no evidence of malignancy. Which of the following is the most appropriate treatment? A, azathioprine, B, ERCP with bile duct stenting, C, pancreaticoduodenectomy or a Whipple, D, prednisone.
All right, just relaunched the poll. Folks are getting their answers in. And while people are kind of getting their answers in, Dr. Demars and Dr. Ray, maybe after this question where, we've been moving through these at a pretty good pace, maybe taking the break a little bit early after we kind of go through the answers to this one. Does that sound okay?
Sure.
Okay, great. I think we'll give a couple more seconds here. All right, I'm going to go ahead and end the poll.
All right. We have still kind of split between B and D, so an ERCP with stenting or prednisone, and then a few people for A and C. So the answer is prednisone. So what's the diagnosis? Anybody want to put in the chat, speak up? We got some people in the chat, right?
Yeah, we've got a bunch in the chat.
Mhm.
I see one for autoimmune pancreatitis, IgG4 disease, a lot of IgG4, probably like 4 or 5 folks voting for that.
Mhm.
All righty. So it's autoimmune pancreatitis. However, that does kind of fall under the IgG4 related diseases. So everyone is probably right. Autoimmune pancreatitis is a systemic fibroinflammatory disease defined as an inflammatory condition causing tissue damage and scarring. It's pretty rare, has an unclear pathogenesis. It's characterized by plasma cell infiltration. And, we talk a lot about autoimmune pancreatitis, but it can affect other organs and often infects lymph nodes. So his symptoms of painless jaundice and the sausage-shaped pancreas are typical for this type 1 autoimmune pancreatitis, which is related to the IgG4 disease. His I don't even know how to say that, sialadenitis. and retroperitoneal fibrosis are associated as well with IgG4. So the treatment is prednisone, and it gets tapered over 2 to 3 months. Symptoms usually resolve in 2 to 4 weeks. Greater than 90% of patients enter clinical remission, but the relapse rate is 30%. So azathioprine would be a second-line treatment. It's used to treat this relapsing IgG4 related disease, especially also if you need to spare steroids. ERCP with stenting is usually not required because they respond so well to the steroids. And a Whipple could be considered to treat pancreatic cancer, but it's not really indicated in autoimmune pancreatitis. Dr. Ray?
Yes. So sausage-shaped pancreas is autoimmune pancreas until proven otherwise, at least for your board's examinations. There's a type 1 and type 2. That's more for the fellows to know, but the type 1 is associated with involvement of other organs, hence the sialitis and the RP fibrosis in other spots. Type 2 is more related with IBD. And this typically responds great with steroids. Sometimes it can present also as a pseudo mass, like an almost head of pancreas mass instead of diffuse sausage shape. So just keep that in mind also.
All right. Question. Oh yeah. Sorry. Go ahead. Question.
No, go ahead. The steroid protocol is typically over a few months. If your patient's still having symptoms after that time, then I would discuss with our advanced endoscopists about doing secondary steps, but this responds pretty well to steroids.
I have a question. I feel like folks often check IgG4 levels in folks with pancreatitis of unclear etiology or recurrent pancreatitis. If on imaging they don't have an abnormal shaped pancreas, does that rule it out, or do you recommend still checking IgG4?
No, I would still check it. Not everyone reads the boards exams and will always present with that sausage-shaped pancreas. So yeah, I would definitely check it if you don't have any other reasons why this patient's having pancreatitis.
Okay, thanks.
When we say sausage shaped, is it literally pinched off like sausages?
Yeah, it looks like thick, fluffy. I don't know if that's on imaging. It looks like it looks like a sausage. Just kind of diffusely enlarged.
Well, maybe we'll take a pause. There are other questions, and maybe come back together at around 9:45. That sound good?
Sounds great. Dr. Demars and Dr. Ray, if you have a second, I wanted to go into a breakout room with you guys.
A 65-year-old male is evaluated after a screening ultrasound for a AAA, which showed an incidental gallbladder findings. He reports no symptoms. He continues to smoke cigarettes, 1 pack per day. He has no other medical problems and takes no medications. On physical exam, his vital signs are normal and his exam is normal. Abdominal ultrasound shows numerous layering gallstones and an immobile 8-millimeter gallbladder polyp. Which of the following is the most appropriate next step in management? A, cholecystectomy, B, MRCP, C, repeat ultrasound in 6 months, or D, ursodiol.
Okay, I've relaunched the poll. You have a message in the chat. Can we have an E, council on tobacco cessation? I think E can be whatever you want it to be, and just share what it is that you're thinking. All right, still seeing answers coming in. So give a few more seconds here. All right. I am going to go ahead and end the poll here. A few people getting in under the wire.
All right, so we are pretty even split between A and C. A couple people for B and maybe one or two for D. So the folks that chose C, can you tell me why that is? What your thoughts are or what you're thinking about this case? Speak up. I can't see who's on, so I
Yeah,
can't
so
call on anyone. But
in the chat, there's from Ruth, it seems like the concerning finding is that polyp.
yeah,
And this is also one where I don't have the sense yet if 8 millimeters is the point where we're just like, take it out, or 8 millimeters is the point where we're saying like, okay, let's see, does it grow? Is it still 8 millimeters next time? And I think that's probably what most of us are waffling about on those choices.
yeah, gotcha.
And Luke in the chat says you don't have to do anything for asymptomatic gallstones.
And in terms of the question about the polyp, what do we, I think Ruth, you were saying about the size. What do we think about the polyp? Why do we worry about it?
I said one more thing came through in the chat from Jordan. Polyp size, I believe, isn't an immediate indication for surgery, asymptomatic. Also surgical risk for, like thinking about the surgical risk for elective surgery with smoking.
What does gallbladder polyp make anybody think about? I feel like it's something you don't ever, I mean, at least I don't know if I've ever had a patient with a gallbladder polyp. It's not, in my experience, terribly common. Dr. Ray might certainly think otherwise, but is there anything you guys know about gallbladder polyps?
Dr. Demars, are you asking me what are we most worried about, or what
Yeah, or like what do you think about with them? Why do you worry about them?
Let's see. We have HLD. For whoever put HLD, can you share what kind of the rest of that acronym? PSC is coming up, malignancy risk, cancer.
Yeah, I'm not sure if you mean hyperlipidemia or for the first one, but yes, cancer is what you're definitely worried about for large polyps, gallbladder polyps particularly.
Yeah. So in this case, I mean, I think this question's tricky because there's lots of like things to know about this, but the answer is A for cholecystectomy. And the reason in this, gallbladder polyps found in 5% of ultrasounds, and only a small percentage are actually malignant. But the things that increase the risk of it being cancerous are the polyp size, like Ruth had kind of insinuated, and also when they are seen with gallstones or in the setting of primary sclerosing cholangitis, and they're more likely or more concerning for transformation into malignancy. And so indications for cholecystectomy are if there's just a polyp alone and it's greater than 1 centimeter, if there's a polyp greater than 8 millimeters in the setting of primary sclerosing cholangitis, and anytime that a polyp coexists with gallstones. So in this patient, because if the gallstone was 8 millimeters without the gallstones or primary sclerosing cholangitis, then C would have been the right answer, but it's because it's found in the setting of gallstones as well. Dr. Ray, got any thoughts?
Yeah, there's updated guidelines on this actually, because I feel like we used to do surveillance on this pretty aggressively. So they kind of updated the guidelines for when you should do surveillance versus when you should do surgery. So the indications listed there are for once you should send patients to surgery. I'm just going to read these here off my phone, so excuse me. So if the patient has a 6 to 9 mil, because I don't have these memorized, if the patient has a 6 to 9 millimeter lesion in the gallbladder and one or more risk factors for malignancy, then you should do surgery. Otherwise, if it's less than like 6 millimeters and no other risk factors, then you actually don't need to do surveillance on it. Risk factors are age greater than 60, history of PSC, Asian ethnicity. If the lesion looks sessile polypoid, which can be a little hard to see from ultrasound, then that is with the size you should consider doing a cholecystectomy.
Great. And there was
we don't have all these memorized.
Yeah,
and this is more like and these are more like radiology guidelines, unless like GI guidelines too. So I have to look these up.
There's also a question in the, or maybe not, sort of question in the chat about for biliary cancer, thinking more, like sometimes we think more about porcelain gallbladder as the imaging finding rather than polyp. Can you speak a little bit to that?
Yeah, so porcelain gallbladder is definitely, very concerning for gallbladder cancer. These polyps are like, we're assuming adenomas have the same risk over if of a greater size and of those other criteria of turning into cancer as well. So that's why that should kind of trigger you to either do surveillance or send them directly for a cholecystectomy with surgery.
So do you think they threw in his smoking because that's an additional risk factor for cancer for him?
I think so. Yeah, because 8 millimeters is also getting pretty up there also. But yeah, him with his smoking history, for sure. But anyone with PSC, like treat those, they are such high risk for cancer. So just send them for cholecystectomy.
All right, thank you. Let's see. All right. Again, I'm so sorry. I cannot read the top line. Can someone else read that?
Got you. A 52-year-old woman is evaluated for mid-abdominal pain and nausea. Symptoms worsen after large meals.
Pain does not improve with bowel movements. She endorses frequent constipation. She's gained 2.3 kilograms or 5.1 pounds over the past year. The pain began 1 year earlier after she was hospitalized with an episode of gallstone pancreatitis, for which she underwent a lap chole. After her cholecystectomy, she had persistent abdominal pain. Over the next several weeks, she had upper and lower endoscopies, CT abdomen pelvis, and multiple labs. All were normal. She states that the only thing that helps the pain is her hydrocodone, but as her dose of hydrocodone has increased, so has her pain intensity. On physical exam, vital signs are normal, BMI 26, tenderness to palpation in all 4 quadrants is noted. Other findings unremarkable. Which of the following is the most likely diagnosis? A, chronic pancreatitis. B, distal intestinal obstruction syndrome. C, IBS, or D, narcotic bowel syndrome.
All right, poll has been relaunched. Still see some answers trickling in. Give you about 10 more seconds here. All right, gonna go ahead and end the poll here.
All right, we have the majority of folks choosing narcotic bowel syndrome. We've got some for chronic pancreatitis, and then the other 2 are kind of a smattering. So can somebody who chose D tell me why they chose that, or what they know about narcotic bowel syndrome and why this patient would fit that presentation? Or it just sounded good because we talked about the hydrocodone and there was narcotic in the answer. I mean, it's a good guess, right?
Yeah.
And if I'll throw myself under the bus here, although I did actually pick A. But narcotic bowel, the things that would really fit for her is that she has this increasing pain with increasing doses of the narcotics. So some sort of, like combined motility defect there. The reason I actually didn't pick it was just like she is having bowel movements, and I would want to know a little bit more about like what that is before I chose that. I could be totally wrong. I'm happy to be wrong. I'll learn.
Sure. Thanks for being bold and speaking up. We appreciate it.
Yeah, I'm seeing some similar sentiments in the chat. I'll be honest, mine was an educated guess. Haven't specifically heard of this syndrome, just picked it because of the hydrocodone. Leah Carlson, many things. So I'm not going to read that one. And Jessica Pinto is echoing that increasing pain with increasing dose of opiate.
Yeah. And what made the chronic pancreatitis folks choose that one, other than Ruth?
Okay, seeing in the chat, location of the pain, worse after meals, starting after surgery, worse after eating.
Sure. Yeah. All valid thoughts.
Do you guys know where you see Dios? Who has Dios? That's B also. Sorry. I shouldn't abbreviate that. Do you know which patient population gets that?
Or what it is.
Yeah.
In the chat,
Yes,
cystic
yes,
fibrosis coming through.
Mm-hmm.
Awesome. Yes. Strong work.
Yeah, so yeah, you see that in cystic fibrosis classically. So okay, and why is this not IBS? Yeah, so someone said not better after bowel movements. Yeah. If you don't get the history of my abdominal pain gets better or worse after bowel movements, IBS, it is not. So think about something else.
Excellent. All right. So yes, the answer is narcotic bowel syndrome. I got to say, the vast majority of everything I've included in here is like from whatever MKSAP wanted us to know about these questions. And I got to say, they didn't have a lot to say about narcotic bowel syndrome. So Dr. Ray, I hope you have more for us. They basically just said centrally mediated disorder of GI pain. And it's just like we talked about, it's paradoxical increase in abdominal pain with increasing doses of narcotics. And then these other kind of comments on why the other ones are wrong, we pretty much already touched on them. So, I mean, the pancreatitis, the patient only had one episode of pancreatitis, and she had gotten a CT scan. There were no pancreatic calcifications, and that pain usually does respond to opiates. As Dr. Ray said, this distal intestinal obstruction syndrome, it's caused by thickened contents that partially block the small intestine, and it's found in patients with cystic fibrosis, typically in the right lower quadrant. There can be some vomiting. And IBS, just like was said, relieved with defecation, pain onset is usually associated with a change in frequency of stool or a change in the consistency appearance of the stool. So that's all I got on narcotic bowel syndrome.
Helpful as well. Lack of, so imaging, if you don't have any calcifications for chronic pancreatitis, if you don't have any pancreatic calcification that leads against a diagnosis of chronic pancreatitis. This patient actually had gallstone pancreatitis. I feel like, so the history I get, because I see this in clinic way too much, more than I want to. The classic history I get in clinic is someone had what they thought was biliary colic, which turned out to be functional abdominal pain, got their gallbladder out and still had pain in the right upper quadrant area. That's classic history. And now they're on these opiates and wondering why they're having abdominal pain. So narcotic bowel syndrome is very, very insidious and tricky because it's hard to convince patients otherwise that opiates are actually causing their problems or actually making their pain worse. So there's very complex neurologic brain gut access disorders and disruptions where the use of chronic opiates will temporarily cause pain relief, but then they get this paradoxical hyperalgesia effect to the opiates. So their pain actually will get worse on opiates and won't get better even if you increase the dose of that. So chronic opiates affect your GI tract globally. So it'll cause gastroparesis, it'll cause constipation. So I tell patients straight up, if they're coming to see me for abdominal pain, I will not give them opiates. There are very specific indications to give opiates for patients with abdominal pain, but you do not treat what sounds like in her functional abdominal pain with opiates. That will not get better, it will just make everything worse. In terms of, doesn't matter when the imaging was performed. So in terms of like the chronic pancreatitis, which I could see why you could think that in her, especially with her history of gallstone pancreatitis, if she was having sphincter of Oddi dysfunction or, concerns for recurrent pancreatitis episodes, that pain is more episodic, and I believe hers was more like chronic daily. And also you should see some corresponding lab abnormalities, such as an elevation in bilirubin or elevated liver enzymes or some maybe biliary dilatation on imaging. So I'll expect to see something there that would make you, or lipase elevation, something like that, that will make you think of there's something wrong with the pancreas biliary. Does giving opiates? No. Oh no, opiates. Once you're on opiates, you're done for. The way we treat that is you have to get your patients off the opiates. That's easy, right? So we have to talk about neuromodulation, which is how you should be treating patients with functional abdominal pain symptoms. So your antidepressants, your TCAs, your SSRIs, SNRIs, and your goal is to up titrate that as you come down on the opiates. A lot of time we work with pain management for this, but no, adding, these things that kind of help opiate effects like the methyl naltrexone doesn't necessarily make things better because they're still on opiates. It's a trap. Don't do it because you create monsters if you put your patients on opiates for chronic abdominal pain. Yeah, they're bad. They're bad drugs to be on chronically. Don't do it. It's a trap. Don't do it.
Thank you.
Mm-hmm.
That was great. All right. 55-year-old male is evaluated at a follow-up appointment 4 days after being diagnosed with sigmoid diverticulitis. He is on day 4 of oral antibiotics and reports that his pain is almost gone. He has no other symptoms and has never had a colonoscopy. He takes no other medications. Vital signs are normal. Abdominal exam is positive for minimal tenderness on deep palpation of the left lower quadrant without rebound or guarding. CT scan of the abdomen from the emergency department shows mild sigmoid diverticulitis without any abscesses. So when should this patient undergo colonoscopy? Now, in 1 to 2 months, in 6 months, or in 12 months?
All right, just relaunch the poll. Well, notice the question is not whether or not to treat with antibiotics, which is another interesting discussion. Mm-hmm. All right, I still see some answers coming in. I have a few more seconds here. Get yours in under the wire. All right, I'm going to go ahead and end the poll.
All right, we've got a mixture. B, 1 to 2 months was the most popular answer, but there's a lot of folks for 6 months or 12 months and a few for right now. So what's if someone can speak up about like what their logic is? Why did they choose that whatever timing they chose?
So we see in the chat, Joey, GI previously has told me they don't want to instrument a hot bowel. And Ruth says it's that sweet spot between resolving his inflammation and not getting C. diff. And Megan says, I feel like he needs one sooner rather than later, but needs some time to recover. And lots of folks echoing that.
Got it. Yeah, and why do we want to do a colonoscopy after someone's had diverticulitis?
I see in the chat from thank you. So maybe the reason we don't, that may have been getting at the reason why we don't want to do it too soon is that risk of perforation. And then reason to do it, look for colon cancer. And then and Kristen.
Yeah, exactly. So, yep, most people had it right. The recommendations are 1 to 2 months. And I mean, 4 to 8 weeks, so the American Gastroenterology Association says. And yeah, it's looking for colon cancer. So they think that about 1 in 67 patients with diverticulitis, you'll find a colon cancer that otherwise would have been missed. And the vast majority of them are right there where the diverticulitis is. You can also assess for underlying IBD would be another reason, but it's mostly to look for the colon cancer. The risk of perforation after diverticulitis is not so clear. The risk of perforation during the acute phase, I don't know where these numbers come from, but it sounds lower than I would have thought. But either way, all of you are correct. I don't think, I mean, Dr. Ray can speak to this, but I don't know any GI docs that would do it when they have an acute infection or acute inflammation. But interestingly, this part I didn't know. If the patient had had a negative colonoscopy in the last 12 to 24 months, then they don't need a repeat colonoscopy. Dr. Ray, do you agree with that?
I do. Yeah, 8 weeks is our typical magic number for follow-up for patients after acute diverticulitis. Again, the risk is the hot bowel risk of perforation. So the risk is pretty low for perforation in general. It's slightly these numbers are still low, like with active inflammation. And I guess honestly depends on how bad the diverticulitis is in general, but just to decrease that risk overall, then we do it 8 weeks after, and we are looking for colon cancer in that area, particularly more so over inflammatory bowel disease. And yes, if your patient has unfortunately like recurrent episodes of diverticulitis and they've had a scope previously, then the risk of you missing cancer with someone having a colonoscopy within a year is very low. So we don't need to put them through that funness of a bowel prep again. Yeah, so that's I think I pseudo answer that question. Yeah, so if they have repeat episodes, if it's like been over a year, then you can discuss, repeating doing a colonoscopy for that. But if it's like a couple attacks, unfortunately, within the same year for that patient, then yeah, don't torture them more than once. And we are kind of, for uncomplicated diverticulitis, we are kind of getting away from antibiotics and treating it more like with anti-inflammatory agents also, because that was mentioned earlier in the chat.
Yeah, such a shift, huh? But when they come in the hospital, we still give them antibiotics.
We do. We're not quite there yet. Yeah, we're not quite there yet, but it's definitely like a paradigm shift we're trying to get around. And Dr. Lisa Straight is diverticulitis. That's her research. So yeah, we're definitely trying to get away from antibiotics, but we still it still happens a lot in the emergency department.
Yep, for sure.
Mhm.
Great. Any other questions or comments on this one? Did something just change in the chat?
Oh, and we're just talking about antibiotics.
Oh,
I was adding some
It's
things.
controversial.
For anyone who was at the Washington ACP conference, I just wanted to mention there was a great presentation by one of our infectious disease docs and one of our GI docs, kind of arguing for both sides of the debate. And then they polled the audience and it was an exact 50-50 split. But it's a nuanced conversation. So
Yes. Mhm.
yeah.
Totally. It's hard to change our practices.
Mhm.
All right. I think, oh, not quite. We're almost getting to the end. I'll tell you all that much. 44-year-old male is evaluated after his routine yearly follow-up for ulcerative colitis. It's evaluated, after his routine yearly follow-up for ulcerative colitis showed LFTs, elevated LFTs. He was diagnosed with ulcerative colitis 5 years ago. He reports he passes solid formed stool every 1 to 2 days without abdominal pain. His only medication is mesalamine. On exam, his vital signs are normal. BMI is 26, hepatomegaly and pulmonary erythema are noted. His labs are notable for an alk phos of 412, ALT of 78, AST 62, T-bili of 2, direct bili of 1.5. His CBC and renal function are normal. His AMA is negative, and his liver biopsy is pending. Which of the following is the most likely diagnosis? A, AMA negative, primary biliary cholangitis. B, drug-induced liver injury. C, non-alcoholic, I don't know, fatty liver disease or steatohepatitis, or primary sclerosing cholangitis.
All right, I've gone ahead and launched the poll. Folks are getting their answers in. All right, still see some answers trickling in. So give about maybe 10 more seconds here. All right, I'm gonna go ahead and end the poll.
All right, most people think it's D, primary sclerosing cholangitis. Does somebody who chose that want to tell me why that was their choice over the other ones?
All right, we've got Tony in the chat. Not sure about A. Don't think mesalamine is associated with liver injury. His BMI is lower. And then remembering an association of ulcerative colitis with PSC. Then Laura says, my same thoughts.
How about somebody who chose A? Anybody want to talk up about why they chose AMA negative PBC? That's okay. If no one else wants to speak up. All right. So
Do you guys know, this might be a more fellow level question, but do you guys know what mesalamine can cause? It is not deadly.
Like mesalamine, usually you had like a normal alk phos and like a more mild elevation of liver enzymes. But I could be totally wrong on that one too.
So it typically does not cause, you typically don't see lab changes with the mesalamine. You have to kind of watch out for their basic electrolytes. But do you know it causes a GI organ inflammation? This may be reading my mind. It can cause pancreatitis. Oh yeah, good job. It can cause it can be one of the drugs that can induce pancreatitis, but it typically does not cause issues with like cholestasis or anything like that.
All right, well, you guys got it again. It was D, primary sclerosing cholangitis. So 5% of patients with IBD will develop this. It is primarily cholestatic, as we saw with the alk phos and the bilirubin elevated. PSC is a structuring process in the medium to large bile ducts. So on MRCP, we see the classic string of beads pattern, which is the strictures and the dilations. So there's a minority of patients who can present with only involvement of small bile ducts called small duct PSC. And in that case, your MRCP is not going to pick up any abnormality. And so those folks typically get diagnosed on liver biopsy. There are, maybe I didn't put it on here. Anyway, small duct PSC has a better prognosis, although 10 to 20% will develop changes in the medium to large ducts. And then I think I included a little bit, yeah, so PBC, also cholestatic LFTs, but they typically, I mean, you know, more of a majority have a positive AMA. I guess there are some case reports of IBD with PBC, but that, I don't know, folks maybe don't accept that so much. It's not as much of a association as with PSC. But 10% of these patients with PBC will have a negative AMA, which also they need a liver biopsy. There are some other, not antibiotics, antibodies such as SP100 and GP210, which can also help support that diagnosis. And then let me see if I said anything about, yeah, so drug-induced liver injury. Not common with mesalamine, but things like azathioprine or TNF alpha inhibitors, which folks with IBD may be on, those can cause drug-induced liver injury. And then non-alcoholic fatty liver disease or non-alcoholic steatohepatitis is now the most common liver disease in the United States, but it typically doesn't have an alk phos that is as elevated as this one. And an MRI would have sensitivity to detect a fatty liver, which was not seen with this patient. Dr. Ray?
Yeah, this is tricky because AMA negative PBC is a thing. It's pretty rare, and for this case, you know, since we didn't have any like imaging to help us, a liver biopsy is definitely needed. There is a more common association between PSC and UC in particular, so that will kind of lead you to the answer for this question. PSC can occur with Crohn's disease also, although the chance of that happening is pretty low overall. There is no good treatment for PSC, unfortunately. It's just kind of liver transplant. Despite, you know, these bile sequestration medications we try, there's really not a good medication for PSC. It's pretty unfortunate. PBC can progress to cirrhosis. So if you have someone with PBC, they can actually get like portal hypertension. I've seen someone get like variceal bleeding from PBC without fully progressing to cirrhosis quite yet, but she was definitely headed that way, obviously, because she was getting portal hypertension. So yes, you can.
Are there more questions or comments? Maybe not. There's a couple things in the chat, but maybe they're not.
Yeah, just kind of a comment
Okay.
on MKSAP questions tend to be hard but fair. No, sorry, board questions tend to be hard but fair, aren't trying to be tricky. MKSAP questions tend to be more tricky because they're meant for teaching, not for the board certification. And John wants to change the names of PSC and PBC to make them different abbreviations. Also IBS.
Right. Yeah, yeah, I agree. I do think so. We're scheduled to end at 10:20, and that's right now, right? So I just wanted to go to the very last slide, only because I specifically chose questions that were not things that I think probably the majority of you see all the time, you know, like complications of cirrhosis or upper GI bleed or stuff like that, because I figured you would kind of all know those. But they did give us at the very end, like the high yield things that they wanted you to know. So you could give them my, you know, my PowerPoint too if they're interested, you know. But so things like that I didn't address because I thought you guys would kind of all know, but patients with GERD, empiric PPIs are like the first line treatment. However, attempts to stop or reduce PPIs should be considered. Women with GERD do not require screening for Barrett's. Patients 60 years and older with dyspepsia should undergo an EGD. Patients younger than 60 should be tested for H. pylori. Enteral nutrition is preferred with acute pancreatitis. Same admission cholecystectomy reduces rates of gallstone-related complications for patients with gallstone pancreatitis. Asymptomatic patients with walled-off necrosis of the pancreas don't require any intervention. We just watch them. Biopsy and ERCP are not necessary to diagnose chronic pancreatitis. Evaluation with imaging, endoscopy, etc., is not indicated for IBS or functional diarrhea. The evaluation of centrally mediated pain syndrome does not require extensive laboratory testing or imaging. Acute diverticulitis usually does not require imaging either. Patients with small polyps should undergo repeat colonoscopy no sooner than 10 years. Patients with uncomplicated diverticulitis. So here it says should be treated with oral antibiotics. So I'm going to leave that one alone. Ultrasound is the best way to diagnose ascites. Asymptomatic hepatic cysts require no follow-up. Focal nodular hyperplasia does not require follow-up. Incidentally diagnosed gallstones do not require cholecystectomy. Cholecystitis can be diagnosed by ultrasound. And in patients with upper GI bleed, our transfusion threshold of 7 is better, is associated with decreased mortality and lengthened hospital stay. So these are just high yield things that, you know, most of them we didn't touch on, but thanks everyone for being here. Any last questions for Dr. Ray before she's got to go?
No, but thank you for taking your time with us.
Thank you guys for being here.
Mhm.
Hope it was helpful.
Yes,
Thank
happy
you
study.
both so much. Yeah, I'm seeing a bunch of thank yous in the chat. A lot of gratitude. Excellent session. Thank you both for being here and teaching us today. Really appreciate it.
It was fun.
Yeah, I think maybe we'll go ahead and take a 9-minute break, come back at 10:35 to start with Dr. Anand to learn about contraception. And yeah, if there are any lingering questions, maybe, I don't know if we can send them along if Dr. Ray and Dr. Demars need to hop off. But yeah, thank you so much for being here.
Thanks.
Thanks, everybody. Thanks, Dr. Ray. We really
Sure,
appreciate
thanks.
it.
Sure.
Thanks to you both. This was great.
Oh, sure. Of course.